Okay, sir. We are live, sir. We can start, sir. Thank you.
Yeah, thank you. Hello, everyone, and I am Dr. Rohit. I am from Medical Affairs team at Dr. Reddy's lab. And at the outset, on behalf of entire Dr. Reddy's family, I would like to wish each and every one of you a very happy Independence Day. By now, I'm sure that each and every one of you are aware that Dr. Reddy's Laboratories has partnered with Fuji Films Japan to launch the innovative brand of Favipiravir, that is Avigan in India. While it is our belief that good health can't wait and it is our purpose, at the same time, we also believe that partnering with scientific community to share and spread the knowledge about the disease as well as the current treatment strategies would go a long way in containing the current situation that the globe is facing. Consistent with our principles of being a scientifically driven organization, I would like to welcome you all to this scientific speaker program on the role of Favipiravir in the management of mild to moderate COVID-19. And for today's meeting, we are extremely privileged to have with us Dr. Richard, who is from Japan and has extensive experience of using Favipiravir even before the COVID pandemic from the Ebola days. We are also very fortunate to have with us Dr. P.K. Thomas, Dr. Animesh Arya, and Dr. Meghnad as a faculty. And we are extremely privileged to also have on board with us Dr. Sanjeev Mehta, who was kind enough to accept our request to be the moderator for today's scientific proceedings. So, Dr. Sanjeev Mehta needs no introduction, but then we all know that Dr. Mehta is a very senior chest physician in the country. He has more than 26 years of experience, was trained in Rhode Island Hospital and Tufts University in the United States of America, has lectured at Rhode Island Hospital, Western Virginia University, Creighton University in the US, and he is the recipient of Dr. C.V. Ramakrishna Oration Award. He is the chair He is the chair of the Council of Global Governors of American College of Chest Physicians USA, has lectured in the United States, Spain, Italy, Switzerland, Czech Republic, and many other countries across the globe, was the only speaker from the country at the first and second Chest World Conference, and has made numerous publications in both national and international journals to his credit, and has also authored multiple chapters in the textbook. So with this, I would hand over the scientific session to Dr. Mehta, sir. Over to you, sir.
Thank you very much, Dr. It's a pleasure to be here. At the onset, I'd like to thank you personally and Dr. Reddy's for having arranged this and this wonderful speaker. This is an important meeting. We were just talking. COVID is in this pandemic is once in a lifetime. I would say once in probably two lifetimes earth-shaking event. It doesn't, this is now after 100 years. We have, and hopefully at the end of today's session, we'll know a little better on how we can deal. When it started, we had no treatment, and today I think is a major advance when we have treatments to deal with this problem. I think I'm honored to be in wonderful company, and I know we're going to start the presentation with Dr. P.K. Thomas. Can we share his, will you share or should I have his introduction?
I will share.
I will do it, sir.
You can do that. Rohit, आप कर रहे हो?
Yes, sir.
Okay, so clearly for our audience, Dr. P.K. Thomas is a chest specialist. V. Krishnaswamy Gold Medal. He's for the best postgraduate. He's presently a senior consultant pulmonologist at the Sri Ramchandra Medical College and MGM Health Hospitals in Chennai, and visiting faculty to Balaji Hospital in Guindy. I've known and heard Dr. Thomas talk to us a variety of topics. His special interest, I know, is airways and community interaction uh, with educating patients on asthma, on smoking, and of course, educating his students. He has lectured at WASOG, NAPCON, ERS, and he will continue to lecture us today. With that, I'm honored to invite my dear friend, Dr. Thomas, to please give us his thoughts on the Indian perspective of the challenges we face in COVID. Dr. Thomas, please. Thank you.
Thank you, Sanjay, for those very, very kind words. It's indeed a pleasure and a privilege to be here. A very good evening and good night to people who are listening. It's a pleasure and a privilege. I thank Dr. Reddy's for having given us the opportunity to really get together. I would like to take, and I think we deal with this we have to deal with this in a sort of philosophical sort of way, because we don't have clear medical answers, and we understand that the moment the circle of medicine disappears, you get the circle of philosophy walking in, and to give you some sort of ethical comfort somewhere along the way and see what best you can do. So I will take you back to thousands and thousands and thousands of years, um, probably to the Garden of Eden, where all things bright and beautiful, all creatures great and small. And this was the way the world was. And I think it was a fantastic world. It was a world that was ruled by this guy who was pretty satisfied with himself. He knew what he was having. He knew his circle. He wasn't very ambitious. There was no corruption at this age. There was absolutely nothing. He ate and he slept and he lived. And I think that must have been a really wonderful time. The problem began when these two guys really started walking in, and the guys below, I think, are the real culprits that we see them today. And what we have reflected in COVID-19 today is this sort of war between nature and man, war between nature and between environment.
Sorry to interrupt, Dr. Thomas.
Yes,
we're not getting your slides. You have to share the screen.
I've shared the screen, really. 1 minute. I'm seeing my screen. But
no, you are seeing yourself, but we are not seeing.
So what should I do now?
Sorry.
Sir, you can go back to this presentation, the Zoom, and below you can share it once again.
Yeah.
You can't see the screen, your slides.
I quit Zoom?
No, sir. You can just close your presentation, minimize your presentation, and share it again.
Dr. Rohit, if you have it, can you share it for sir?
Yeah.
Sir, Dr. Rohit will be sharing your slides, sir.
No, I would like to keep moving them if it's possible. So I'm wondering if I got it actually. What happened to that? I don't know.
Thomas,
Yeah.
you are on the screen. As you move your cursor, at the bottom there'll be a green button with share screen. If you go all the way down to the bottom with your arrow, do you see a green button light up saying?
No, I don't see that at all.
Slides.
Now do you see? No.
No, sir.
Huh?
No, sir. We can't see right now.
Okay. I don't know. Then I think you do it. Do it yourself. I think that'll be the best. Let's not waste time.
Yeah, Rohit.
I don't think this is a time to learn.
Yes.
We should have learned already, which we have not. Go back. I'm really sorry. I apologize for this.
Just a second, sir. It's 30 MB file, so it's loading.
This thing was working then, and now it's gone for a 6.
So if you can just minimize your presentation and then again reshare it, it will be possible.
Oh, I minimize this and then reshare, is it?
Yes,
Okay.
sir. Reshare. You minimize. Once you see all of us on the Zoom, you can
I
again.
see only you, Dr. Rohit. I don't see everybody else. I minimize the presentation, then I go back and I've shared it now. Now, are you able to see my screen? No. Oh my God.
There you go, Dr. Thomas.
Would you, Dr. Richard, would you finish? Then I take take it from there for time's sake. I think we will.
Yes, sir. I think we should do that.
Yeah, I think we should do that. I don't honestly think we should keep people waiting, really.
Yeah.
I think we should let Dr. Richard go first, work this out, and then, oh my God, I don't know what's happening.
Okay. I think we're going to disappoint our audience because they're not going to be able to see the dinosaurs. But I don't mind taking
Don't worry,
a
they
crack
can
at
wait.
it. Okay. Do we want to do an intro first, or do you want me to just jump in?
Yeah, I think so. Dr. Richard, you please jump in and get it done. Yeah.
Okay.
So Mehta sir, would you please introduce Dr. Richard, sir, so we can move on to the next presentation.
So while we have Dr. Thomas sort out his presentation, it's my pleasure and privilege to introduce the next speaker, Dr. Richard Kaczynski. Now, we are very fortunate to have Dr. Kaczynski with us because his CV is so impressive that it takes some reading. He is the co-founder of Stanford Solutions, which is a healthcare innovation company out of Stanford. Part of what Stanford Solutions does is provide a source, a common platform where innovators can come together and think of future treatments. And I think this is a brilliant space to be in, and what an amazing concept. He's also the senior medical advisor to the Embassy of the Democratic Republic of Congo in where I understand that he is leading the advice on how to contain, control, and deal with the Ebola epidemic. So he has a tremendous insight into this viral infections. He has previously studied at the University of Tokyo in Japan and at the prestigious Harvard Medical School. He has also, I understand, at the University of Nagoya and Kobe. So he's been around quite a bit for such a young, tremendous experience. He's a member of the American Association for the Advancement of Science, a recipient of the AAA Award for Excellence in Science. He's a recipient of the JASSO Honors Scholarship. He's a recipient of the COE scholarship, and he is a speaker at various national and international conferences. So I think we are privileged to have him. He has spoken extensively and worked extensively on Favipiravir.
Okay, so thank you very much, Dr. Mehta, for that fantastic introduction, and a big thank you and hello to our friends at Dr. Reddy's, Deepak, and Dr. Rohit, and Dr. Sagar. It's also quite an honor to share this platform with the titans of the scientific community, like Professor Thomas, Professor Mehta, Professor Arya, Rajan, Dr. Ashish, and everyone. Thank you very much for taking the time to join us here today. I think, we're witnessing something that we've really never come across in the history of science and the way that science information is disseminated. And what I speak of specifically is right now in the COVID-19 age, we are experiencing an overabundance of information. And never before have we seen such a rapid cycle of information and disinformation. So what's true one day is flipped over upside down, and the next week it's the complete opposite of what it was a week before. So what I really wanted to do, and I wanted to make a special effort to join you here today to try to dispel some of the rumors that have been circulating around with regard to the drug Favipiravir. I understand that a good portion of our audience today are doctors who are on the ground, who are treating COVID-19 patients on a daily basis, and who have yet to actually come across using Favipiravir in this specific strategy just yet. So I do want to make a specific point to just try to dispel some of these different rumors. Anytime you start working with a new drug, especially a new drug that carries with it the potential risk of teratogenicity or fetal toxicity, the rumors kind of run rampant. And you really wouldn't imagine some of the strange rumors that I've come across. Some of the more absurd rumors would be, oh yeah, when I was in Africa, one of the doctors there said, yes, I know this drug very well. This is the drug that makes your penis fall off. Yeah, and I said, yeah, it doesn't make your penis fall off. So gentlemen, you can rest easy. But there are certain types of rumors that kind of go around, and it's important for us to properly disseminate information so that the people on the ground can convey to the patients on the ground the proper use and the proper risks associated with the use of this drug. So I think a good place to start off with the presentation is to just kind of go across and go through the background of where we are today in the COVID-19 world. So as of August 15th, 2020, the number of global cases has exceeded 21 million worldwide. The number of daily cases continues to increase, with the latest data on August 13th confirming 260,000 new cases. When we actually look at the distribution of cases, the top 3 countries that are affected by COVID-19 and who share the majority of cases worldwide are the United States, Brazil, and your country, India. So in the United States, we have more than 5.4 million cases, followed secondly by Brazil, which currently has more than 3.2 million cases. And in third place, we have India, which currently has 2.5 million cases. So what's important to know when you look at the distribution of cases on a worldwide basis is that these 3 countries, the distribution for these 3 countries alone accounts for more than 50% of all cases worldwide. And so one way that we try to gauge and make sense of what's going on with how the virus is spreading or how deadly the virus is we try to use something called the case fatality ratio. Now, the case fatality ratio is actually a pretty poor measure when we're talking about the mortality risk of the disease, but it's a good indication to go by. And it's also important to note that the case fatality ratio is something that changes constantly over time as we get more information. And so when you look at this graph here, the case fatality ratio, which is simply the ratio between the number of confirmed deaths and confirmed cases, in Italy, we have a case fatality ratio of 14.3%. In Spain, we have a case fatality ratio of 8.5%. Now, the global case fatality ratio at present is 3.6%. But again, like we just discussed earlier, the case fatality ratio is a very fluid number. It's a number that evolves over time. So what we see today is 3.6% as the CFR for August 14th, could very well be above 5% a month from now, or maybe 6 months from now. So it's a number that tends to fluctuate. And before we actually get into the drug and the drug safety and efficacy, another good place to start off this conversation in this presentation is to go into the background of the virus that is causing so much mayhem across the globe right now. And of course, we speak of the SARS-CoV-2 virus. So the coronaviruses are basically enveloped RNA viruses. The coronavirus is a positive sense, single-stranded RNA genome virus. And the details of the properties of coronaviruses were actually first published in Nature back in 1968. And in contrast to popular belief, the original virologist at that time actually compared the characteristic fringe of projections on the outside of the virus with the solar corona on the bottom right hand of your screen, and not as the points of the crown, which is believed right now in mainstream. It's important to note that the coronaviruses are the second most prevalent cause of a common cold next to the rhinovirus. And this particular virus does tend to replicate at lower temperatures, and thus there's a predilection for upper respiratory tract infections. So when we talk about human endemic coronaviruses, there's actually four types that use humans as their primary hosts. And this is, of course, the 229E, HKU1, NL63, and OC43. So these account for up to 15 to 30% of all human colds. So the problem with human endemic coronaviruses is that there really is no durable immunity, and therefore the patients will undergo frequent cycles of infection. Another thing that you'll notice is that, like we discussed a little earlier, it's the upper respiratory tract that tends to be the most common site for infections for human endemic coronaviruses. The lower respiratory infections do tend to occur, but they do tend to occur in immunocompromised hosts or patients who are otherwise undergoing some sort of chemotherapy or other forms of aggressive treatment that would render the patients in an immunocompromised state. Now, before SARS-CoV-2, we did notice that the coronavirus did have a distinct seasonality, appearing generally around the winter and staying until early spring. So really, the SARS-CoV-2 and COVID-19 is not the first time that we've come across the coronaviruses. So back in 2002 to 2004, we still remember the severe acute respiratory syndrome that resulted in more than 8,000 cases with a 10% mortality, which spread to more than 30 countries in 3 months. So this particular strain, the SARS-CoV, was thought to have originated in bats. It's thought to have transmitted to civet cats and raccoon dogs before jumping to humans. And for those of you who haven't seen civet cats, here's one right now on screen. And if you don't know what this is right here on the bottom right corner of the civet cat, this is actually the poop. This is actually the feces of the civet cats. So it's called Kopi Luwak. It's probably one of the most expensive coffees that you'll encounter on the planet. So for those of you who like feces in your coffee or coffee in your feces, this is perhaps something that maybe you'd like to try in the future. Next, we have the MERS virus, which is the Middle Eastern version. And this is still kind of new, and it's recently imprinted in our minds, in our memories, due to the fact that it infected more than 2,500 patients. It resulted in a much higher mortality than the SARS-CoV cousin, and it did spread relatively rapidly to 27 countries. The difference between the SARS-CoV back in 2002 to 2004 and the MERS-CoV is that the same origination for bats, as opposed to jumping to civet cats, this virus jumped to camels, and then from camels to humans. And now, of course, back in late December of 2019, humanity has come across the latest form of the coronavirus, which is the SARS-CoV-2 strain. So currently, there's more than 21 million cases worldwide. The mortality is thought to be anywhere between 1% to 2%, and it's spread to more than 200 countries. This particular strain is thought to have originated in bats. It's thought to have made some sort of transmission to snakes and pangolins, which is on the bottom right-hand corner of your screen here, and then jumped to humans. So I think what's interesting to note is that the SARS-CoV-2 actually shares 90% of genetic material with the coronavirus that infects bats. The CFR, what was originally thought to be about 4.3%, is at the latest data 3.6%. There are a number of clinical presentations that we deal with when we're speaking of coronavirus. A lot of these are non-specific, meaning that we'll see a lot of these symptoms in patients outside of COVID-19, which makes the diagnosis a bit tricky. So a good meta-analysis that was just released by a group published by Dr. Ali et al. Studied 61,000 patients. It was a meta-analysis, and they found, of course, the most common clinical presentation associated with COVID-19 was a fever, which was found in 87% of patients, followed by cough, fatigue, sputum, myalgia, and so forth. What's actually interesting is now, once the patient has actually recovered or has gone negative for the virus, we are still noticing that the patients display residual symptoms even in the recovery phase. And this was actually addressed very well in a paper that was published in July 9th in JAMA. So one of the more common symptoms that are associated with COVID-19 that tend to become residual symptoms for a longer period of time, even during the recovery period, is fatigue and dyspnea and joint pain. These would be the top three symptoms that tend to kind of drag their feet and stay with patients long after they've entered the recovery phase. So when we try to classify the severity of symptoms, the FDA has come up with two different types of ways to classify the severity categorization. And so one way to do so is based on the clinical signs that the patient is presenting with. So a simple way to do that is to try to do the categorization based on 4 categories: mild, moderate, severe, and critical. The difference is basically what's on screen here. The mild patients will have respiratory rate under 20. Saturation would be above 93% on room air, and the heart rate would be below 90. So whenever you have any category that fits the next category of severity. So for example, if you have a patient with respiratory rate of 16, saturation 98% on room air, but your heart rate is, let's say, 120, then that patient would be classified as moderate according to their clinical signs. Another way to do the categorization is based off of symptoms. Again, it's mild, moderate, severe, and critical. Basically, the symptoms that are associated with mild patients will be mild symptoms, including fever, cough, sore throat, etc., but without shortness of breath or dyspnea. So the moderate patients will present with the same sort of symptoms that you would find with mild cases of disease, such as fever or cough, but these patients would present with shortness of breath with exertion, so exertional dyspnea. For the severe patients, you'll notice shortness of breath at rest or respiratory distress. And the critical patients would be the patients who are presenting with any of the following critical symptoms, such as respiratory failure, shock, or MOD or MOF. So let's get into the background of the drug a little bit. So Favipiravir is basically a small molecule nucleic acid analog. It's an oral pill, which is well absorbed after administration. And it specifically targets the RDRP, or the RNA-dependent RNA polymerase, that's found across a broad spectrum of RNA viruses. And so what's special about this what's special about this drug is that it has a very high genetic barrier to the development of viral resistance. So we know that certain drugs, such as Tamiflu, for example, have already given way to a pretty significant portion of viruses like the influenza virus that have grown resistance to this drug. But for Favipiravir, we know that it's difficult for the for the viruses to try and play catch up. So the pharmacology is now pretty well known. There's more than 180 non-clinical animal studies that have been performed to date. The safety database with regard to human data is pretty extensive. More than 3,100 patients were recruited for the influenza program, and more than 35 clinical trials are currently ongoing at various phases worldwide for COVID-19. So very simply, to go over the mechanism of action for Favipiravir, is once Favipiravir is ingested and absorbed into the system, Favipiravir is first incorporated into cells, where it is converted into Favipiravir ribofuranosyl phosphates by the host cell enzymes. From there, the triphosphate form, which is Favipiravir RTP, inhibits the viral RDRP, and this is how it exerts its actions. So as we discussed a little earlier, we know that the drug Favipiravir has a very broad spectrum of activity across a broad spectrum of RNA viruses. And some of these viruses are of course the influenza viruses, Lassa fever, Bunya, filoviruses, Ebola, Marburg, etc. And so this is one of the reasons why at Stanford Solutions we started to look at this drug. One, because it has such a broad spectrum of activity. And also one of our goals at Stanford Solutions is to try and identify drugs that will provide sustainable solutions to a broad spectrum of social and economic populations. So we want to make sure that we're trying to target a drug that can reach every facet of society, not just the incredibly rich, not those with the best insurance policies, but pretty much anybody. And this is why we're very excited about the use of this drug. So let's take a look at the background and safety. Anytime you see, Favipiravir in the news, you'll probably see it with a caveat. For example, with the New York Times, you'll see this drug may cause birth defects, and Japan's pushing it for coronavirus. Or, for the Wall Street Journal, Japan tests a coronavirus drug despite the danger of these birth defects. Or Abe touts the Avigan as COVID-19 treatment despite experts urging caution. So, there's a lot of pushback against the use of the drug because of the animal testing that has shown that in certain animals, the drug has been known to induce teratogenicity or fetal toxicity. But when we think about drugs on the broad scale level, we have a lot of drugs that we use today that have some sort of teratogenic effects that we should be mindful of. I'll give you one example. Warfarin is a drug that's used by more than 1 million patients in Japan, but it does carry the risk of teratogenicity. But are we preventing the use of warfarin, or every time you see warfarin in the news, do you see that together with the words, okay, warfarin is exerting these effects, but it's a dangerous drug that causes birth defects. You don't see that in the news. So it's very unique that for this drug, you're seeing that quite often, when in reality, when you look at the drug's use, and the drug has been used on different illnesses spanning from influenza to Ebola to Marburg to different types of RNA viral infections. But not one case of documented fetal toxicity or teratogenicity has been documented in human cases. And one of the reasons why we've been able to achieve such great safety legacies for the use of this drug is because we've been very cautious to make sure that we do not dispense this drug or administer the drug to pregnant women or lactating women. At the same time, we strongly prohibit men from engaging in unprotected sex for a period of 7 days after discontinuation of the use of this drug, specifically due to that risk of potentially inducing teratogenicity or fetal toxicity. So we'll discuss that more in detail later on. But before COVID-19, the safety profile was well established in more than 3,100 patients with Favipiravir. So more than 40 clinical studies have been conducted with Favipiravir, and 33 of these were phase 1 trials, 17 of which were conducted in Japan, 16 of which were conducted in the US. 3 of the 40 clinical studies were carried out in as phase 2 studies, 1 which was carried out in Japan, and 2 were carried out in the US. 4 phase 3 studies were conducted, 2 of which were Japanese studies, and 2 of which were US studies as well. Now, in the corona age, we've actually seen more patients being administered the drug. The safety is well established in more than 2,500 patients now, and no new or unexpected or serious safety issues have been reported to date with regard to Favipiravir in COVID-19 studies. So the most common adverse effect reported with Favipiravir is the hyperuricemia, which is found to be very transient and manageable and reversible after stopping the administration of the drug. So the safety profile, with regard to COVID-19 studies, there's a number of studies that have been carried out in Japan, in the Russian Federation, in China as well. And, all these studies have been pretty consistent with regard to their safety profile. And before we actually go into the efficacy of the drug on COVID-19, I just want to go ahead and share with you what we were trying to do with the drug in the Democratic Republic of the Congo during the Ebola outbreak. So the Ebola outbreak that has been since contained was first declared in August of 2018. And this was the 10th outbreak of Ebola that was centered in the northeastern region of DRC. And as of December 31st, 2019, there were 3,200 confirmed cases, 2,200 deaths, and the case fatality ratio was 68%. And so, it's also important to note that not only does the Ebola virus and the Ebola epidemic carry a very high case fatality ratio, meaning that 2 out of 3 patients who actually contract this virus and actually develop the disease will be dying from this disease. And it's also important to note that a significant number of healthcare workers were also infected by this virus as well. So when we look at the way that we were managing Ebola, there's 2 broad areas that we normally look at when we try to manage any form of viral outbreaks or any form of outbreaks for that matter. So there's, on one hand, we have prevention, which is achieved by vaccination, and on the other hand, we have treatment, which resorts to therapeutics. So on the preventive arm of this Ebola management, we had a number of experimental vaccines. So we had the VSV EDOV, which was manufactured by Merck. This is the current vaccine that is in use in the DRC, and it's very convenient because it's a single dose vaccination. There's also another vaccine manufactured by Johnson & Johnson. This is a 2-dose heterologous regimen, but it's not very effective in terms of the way that it's administered. So we're seeing that with the 2-dose regimen, not a lot of patients are coming back to get their second dose. And so that becomes a problem. Not only that, but the vaccines, whenever you see the news about the vaccines, you'll see that it has 99.99% success rate. But when you actually go into the northeastern region of the Congo, and when you actually go into the epicenter of the outbreaks, we're actually seeing the patients who have been given the vaccine who are actually developing the disease. So, while we remain hopeful that a vaccine will be developed for COVID-19, our experience with Ebola teaches us that we should always be careful and always have a plan B in place just in case, because not everything you see in the data is always correct. So it's a painful lesson that we learned, but it was a lesson learned nonetheless. So on the treatment arm, we've seen a great paper that was just published in the New England Journal of Medicine in December of 2019, which compared 4 antivirals. So we have Regeneron's RAG and EV3, MAB114 that was developed by Ridgeback Biotherapeutics. We have ZMapp and Remdesivir. So in the New England Journal study, they found that the mortality for Regeneron and MAB114 was reduced to about 29% and 34% respectively. So now this gives us a lot of hope on the treatment end of the spectrum, but when you look at things in the broad spectrum of things, we can still see that even if you're lucky enough to get these newest forms of treatment, you're still looking at 1 out of 3 patients who will be dying from this virus once you actually contract and develop this illness. So one thing that we weren't really looking at was post-exposure prophylaxis and pre-exposure prophylaxis. And this is something that's been marginalized in our management of COVID-19 as well. And it's a very important aspect that we could be looking at and that Favipiravir could be fulfilling before a vaccine is properly manufactured and disseminated for widespread use. So now, aside from the lengthy preamble, when we're talking about the efficacy and the effectiveness of Favipiravir against COVID-19, one of the first papers, which was an in vitro paper published in Nature, went ahead and showed that Favipiravir demonstrates in vitro effects against SARS-CoV-2. So this was really one of the first pioneer studies that said, well, it definitely looks like this drug could be effective against COVID-19. So with regard to the clinical evidence, there's a growing body of evidence that shows that the drug does seem to be effective, or at least very promising in terms of becoming a potential therapeutic for COVID-19. So efficacy data on COVID-19, there's one major observational study in Japan with an N of 2,158 patients that we'll be discussing today. There's 2 clinical trials that have come out of China. There's 1 clinical trial out of Russia, and there's another exciting trial that has come out of India. So the first study that I'll be sharing with you is the Japanese study. This is one of the most interesting studies that have actually been published to date in Japan. One of the drawbacks, of course, is that it's an observational study, but nonetheless, it was an observational study under which Favipiravir was administered to hospitalized patients with COVID-19, and the drug was basically used on a compassionate use basis. So the objective of this study was to basically try to delineate what the comorbidities were for patients who were receiving antivirals, the severity of the illness, what other types of medications were targeting SARS-CoV-2, what adverse events were likely related to Favipiravir use, and the clinical status 7 and 14 days from the start of the drug. So the study actually started in February of 2020. It was still early on in the pandemic. It recruited, or actually, I'm sorry, it registered more than 2,100 patients from 407 centers throughout Japan. And so the dosage that we used in this particular compassionate use basis was 1,800 milligrams BID on day 1, followed by 800 milligrams BID from day 2 up to day 14. The median time, the median duration of the administration of the drug was 10.4 days. So when we look at the age distribution of patients that were given Favipiravir in this study, you can see that most of the patients, the vast majority of patients, were above the age of 50. And this is actually pretty important that we focus on patients above the age of 50, because we know that the case fatality ratio, or the proportion of severe cases, increases with age. And so when we look at the underlying diseases of these patients that were registered in this study, we find that the underlying diseases were fairly common. In particular, diabetes and cardiovascular disease, which was prevalent in 24 and 25% of patients respectively. And it's also important to note that a number of patients had a number of overlapping comorbidities and underlying diseases. And about half of the patients, so more than 1,000 of the patients who were registered in this trial, had at least one of these conditions. So again, this is just a reflection on the rather elderly population that was registered in this particular study. So when we actually look at the endpoints, the clinical course after 7 days of Favipiravir administration, when we look at mild, moderate, and severe diseases, was, we had a pretty good portion of patients who had shown improvements in both the mild to moderate categories of disease. For severe patients, we didn't notice a great deal of effectiveness, but we did see some very promising results. So again, by day 7, we were seeing 74% of patients improving in the mild disease category, 67% of patients were improving in the moderate, and 40% in the severe category. So very promising results. When we actually move over to the 14-day landmark, we see that nearly 90% of patients in the mild disease category were actually showing improvements. In moderate cases, by day 14, which is 2 weeks, we were seeing 84% of patients showing improvement, and in 60% of patients in the severe category who were showing improvements as well. So these are very promising results, but again, we do have to take this with a grain of salt, because this was an observational trial. There was no control group, and so it's not a very well controlled trial. It's simply a matter of, we go to the patients, we ask them, are you interested in being administered this drug? Here are the known side effects, here are the known efficacy data, what would you like to do? And basically that was the criteria for us to give and administer the drug. So when we, what was interesting about this particular observational study is that they actually looked at what the clinical outcome was 1 month from admission. So, what was the final outcome of those patients? So for the mild patients, 61% of the patients were discharged alive 1 month after admission. 42% in the moderate categories were discharged alive, followed by 14.7% of patients who were discharged alive in the severe category of disease 1 month after admission. So again, the final mortality rates are subject to change, because some of the patients were transferred for escalation of care or were hospitalized for extended periods of time when this data was released. So we would have to go back and do a follow-up to get the latest data on this. So anytime that we're looking at a new drug, we're always trying to balance two things. We're trying to balance the efficacy of the drug and effectiveness versus the safety of the drug. So when we just looked at the efficacy and effectiveness, but now it's time to look at the adverse events that are associated with the drug. So of the more than 2,100 patients who were registered in this trial, the most common adverse event associated with the use of the drug was hyperuricemia, which was found in 15% of the patients. Liver function abnormalities were noted in 7.3% of patients, followed by RAS, which was found in 1% of patients. From there on, we see a number of other adverse events, which were prevalent, but at a rate of less than 1%. So now in China, they did a number of interesting studies as well. The first study was conducted by Kai et al. The objective of this study was to evaluate the efficacy and safety of Favipiravir on COVID-19. It was an open label, non-randomized trial, which involved two arms. The first arm was an arm that was given Favipiravir plus interferon and standard of care versus the control arm, which was Kaletra, Lopinavir, and Ritonavir combined with interferon and standard of care. Basically, they were able to recruit 35 patients and put them in the Favipiravir arm and 45 patients in the control arm. So some of the endpoints that they used was viral clearance, which was defined as the presence of 2 consecutive negative results with a positive PCR detection over an interval of 24 hours. The other was improvement of chest CT scans on day 14 after treatment. So when we first look at the amount of time that it took for viral clearance to occur, the median time of viral clearance was significantly shorter for the Favipiravir group compared to the Lopinavir-Ritonavir combination group. So we're looking at a median time of 4 days to viral clearance in the Favipiravir group versus a median time of 11 days in the combined Lopinavir and Ritonavir group. So in patients with mild to moderate COVID-19, Favipiravir treatment was associated with significantly shorter time. So this is something that was very promising with the study. In addition to this, what was also exciting was by day 14, which is 2 weeks after treatment, they were noticing improvements in the chest CTs of Favipiravir patients. So basically, in 91% of patients in the Favipiravir group, they were noticing improvements in the chest CTs of their patients who developed pneumonia. When we compare that against the Lopinavir-Ritonavir group, on day 14, that group was seeing 62% improvements in chest CT. So again, 62% is a very promising result as well, but it's nowhere near the 91% that was achieved with Favipiravir. So again, in this study, they also looked at a number of side effects that were associated and a number of adverse events associated with use of Favipiravir and also with Lopinavir or Ritonavir. So what they found was in the Favipiravir group, the total number of adverse events occurred in 11.4% of patients versus 55% in the Lopinavir and Ritonavir group. In addition, they found that diarrhea was a common occurrence, but it's very difficult to try and attribute this specifically to the use of the drug. So another study that came out of China that was authored by Chen et al. Was comparing Favipiravir versus Favipiravir, which is another oral broad-spectrum antiviral drug. So this study was a prospective randomized control open-label multi-center trial in adult patients. It was looking at 236 patients who were diagnosed with COVID-19 pneumonia. The primary endpoints were clinical recovery rate at 7 days from the start of treatment. So in the first group, in the first arm, you have the Favipiravir group, which had 116 patients who were treated 1,600 milligrams BID on day 1, followed by 600 milligrams BID on day 2, up to a period of 7 days. The Favipiravir group was treating 120 patients for a duration of 7 days at 200 milligrams TID. So here's the schematics. And the primary endpoints were defined as the clinical recovery rate at 7 days from start of treatment, axillary temperatures of 36.6 degrees or less, respiratory frequency of 24 or less, oxygen saturation of 98% or greater with mild or no cough. So here's what they found. For ordinary patients with COVID-19, the 7-day clinical recovery rate for the Favipiravir was 55.8% and 71% with the Favipiravir treatment group, which was statistically significant. For other ordinary patients with COVID-19 and patients with hypertension or diabetes, the time of fever reduction and cough relief in the Favipiravir group was also reduced significantly as well. So the latency, so the time of cough relief and fever reduction in the Favipiravir group was also significantly shorter than that of the Favipiravir group. So again, the same way they looked at the adverse events associated with the drug used for both Favipiravir and Favipiravir, and they found that in the Favipiravir group, they found 31% of patients who had some sort of adverse events versus 23% of patients in the Arbidol group who complained of adverse events. So the most common side effects in this particular study associated with Favipiravir was the hyperuricemia, which is consistent with other studies published to date. In addition to that, we have digestive tract reactions such as diarrhea that were reported in approximately 14% of patients, and abnormal LFTs that were reported in approximately 8% of patients. So the Russian Ministry of Health also has approved of a Russian study, and what they did in the Russian study is by day 4, they found that the use of Favipiravir resulted in 65% of patients turning RT-PCR negative for SARS-CoV-2 by day 4, which is pretty consistent with the data that has been published by the Chinese groups. And also on day 10, they found that 90% of patients who turned negative for RT-PCR for SARS-CoV-2. So in less than 2 weeks, 90% of patients were turning negative for RT-PCR. I'm going on a little long, so I'm just going to go ahead and jump forward with these slides here. But there are a number of ongoing clinical trials, not only in China and Japan and India, but also in the UK, and the US, Russia, France, Italy, and now most recently in Kuwait. So just to give you, sorry, misspoke prospects, but there is a growing body of evidence for supporting the efficacy for COVID-19. There's more than 35 clinical studies that are either ongoing or that have been completed to date. And there are a series of promising clinical investigations that have led to approval for Favipiravir for emergency treatment of COVID-19 across the globe. And the safety profile continues to be well documented. We're not seeing any new or unexpected or any serious safety issues that have been reported with regard to Favipiravir's use in COVID-19 studies. And the data that we're seeing right now from various studies are very consistent with previously published safety studies as well. And of course, the most common of which is the hyperuricemia, which it's important to note that is transient, it's manageable, and it is reversed after stopping the drug after administration. There was a study published about 3 days ago in Japan, a case study that showed that the use of the drug on a 42-year-old gentleman in Japan with a history of type 2 diabetes, dyslipidemia, and also a high baseline uric acid level did develop a acute gouty arthritis. So we should be careful in patients with a high baseline uric acid level. But aside from that, we're not seeing anything new or very serious come up. And again, the safety profile of Favipiravir was found to be very similar to placebos in RC randomized control trials and other studies that have been conducted to date. Again, this concludes my presentation. We're very excited again to hear about Dr. Thomas's fantastic presentation with a bunch of dinosaurs and apes. So stay tuned, and thank you again for taking the time to listen and chime in.
Thank you, Dr. That was a fantastic presentation, um, very well laid out and very well researched. I learned a lot. Dr. Thomas, are we ready with your presentation?
Um, just working things out. Cannot.
Richard has to stop sharing the presentation, then only Thomas can do it. Dr. Richard?
They must stop. No, okay. Cannot. No, that's still not stopped.
Oh, okay. Let me see. There we go. How's that?
Yeah,
Okay.
done.
Yeah. Are you able to see me?
Yes, sir. You are seeing some dancing angels.
Okay.
We got the angels.
Okay. Yeah, is that okay? So I think we go back.
Now we got COVID.
Okay, we got COVID. Okay, right. Thank you very much, Dr. Richard. That was a wonderful presentation, and thanks, Sanjay, for that very good introduction. It's been a great evening so far, and I think we'll try to divulge into something. Mankind has always been confronted with these types of catastrophes down the line. And every time we confront a catastrophe like this, we always think about two things. One, we ask ourselves the question why, for which there is no answer whatever. And then what we do is try and look backwards and see what is it that we have done wrong that has brought us into this situation. And that, ladies and gentlemen, is exactly what I would like you to see. We really don't know if this guy lived in a better world than what we are living in today. He was extremely, what shall I say, extremely satisfied in his circle. He had the food to eat. He had the time to rest. He was never very avaricious. He was not looking for territories to conquer or sciences and arts to conquer as well. And he was quite comfortable in his zone. The minute these guys started walking in, I think our problems really began. And the guys at the bottom are really the culprits that need to be called into question. The minute mankind walked into this very serene world where all things bright and beautiful, all creatures great and small were living, one really understands that this battle between man and nature began many, many years ago. And I think the culmination of what we see today is the ultimate fact that man has hit nature and nature is now hitting back at man. And that's the philosophy of life that we learn at this point of time. So if we continue to do what we are doing, ladies and gentlemen, there will be no more Rafales and Sukhos to fight our wars. There will only be this sort of vial of virus that they shown us in the movies. You just shove it on the next country and the next country will go for a six. So this is a slide that I have stolen from my very good friend, Dr. Murali Mohan from Bangalore. And I will get a post-dated approval from him. Ring a roses, a pocket full of poses, a tissue, and we all fall down. I believe this was during the London plague. And they used to run around in circles with poises, means herbs that they would put in their pockets. And then they felt that the herbs were curing them and all of them would fall down dead. And that's precisely something close to what is happening at this point of time. I think we've seen all this. We've seen the quantum of virus and we've seen the spread of the virus. I think we'll skip all this for the time being. Deaths without sequelae, deaths with late sequelae. I'd just like to spend a minute on deaths with later sequelae. What we are really coming to see at this point of time is a huge number of patients who have recovered from COVID and who are left with sequelae. What sequelae? Sequelae which are related not only to sort of systemic side effects like body pain and aches, which eventually we think will go off, but also are left with breathlessness and clear CT findings which approach to something like fibrosis. And I think there could be an entity down the line which is called post-COVID fibrosis or whatever it leads to, we really don't know. Even today, there is talk about using antifibrotics early in these patients, even during the course of COVID to try and prevent a post-COVID fibrosis. Whether a post-COVID fibrosis will act like an IPF or not, I'm not quite so sure. And I think that's absolute uncharted territory that we need to get into that. But I think a philosophical person will look at it this way, look at the number of road accidents that we have. But the point that we need to understand that these road accidents are spread over a period of time, whereas COVID is killed in 3 months, what the road accidents probably kill in a year or two. And I think that's what we need to understand. The speed and the rapidity with which it has progressed, I think is important. I think we'll skip all this. Dr. Richard has gone through all this. We know that ACE2 expression is in various tissues. Um, Here, of course, it's got this propensity for the nasal and the oral mucosa. And I think we need to understand that it can be a widespread systemic involvement as well. We've talked about droplet infection. We've talked about segregation. We've talked about social distancing. And I think this is something that's slowly getting into our DNA. And we are trying to do it. And I think we're trying to do as good a job as we possibly can. And only the future will tell us if we have been really successful. Now, how long does the virus last has been a question which has been debated very, very frequently. As aerosols in the air, very, very short time, I don't really think there is a very huge air-like spread like we have in measles for that matter, which is supposed to spread more than 100 meters. On stainless steel and cardboard and things like that. Today we have things on Amazon which are advertised for cleaning surfaces. You clean the surface with that, then it goes out. Now this is something we'll be talking about for a very long time to come. So the clinical period, I think we've already seen that 1 to 3 days prior to symptoms, clinical being fever, cough, and all those things put together. Lymphopenia, increased D-dimer, LDH, CRP, ferritin, all things I think Dr. Richard has dealt with. The stages I think is already seen. I don't really think we need to go into it. The incubation period and the period of illness, as we'd like to, the median days after development of sickness or illness. And I think this is very important. You know, an ordinary influenza virus probably gets in a lot too faster than the SARS-CoV-2. The SARS-CoV-2 sometimes takes about 5 days to 1 week. And by that time, he's sort of forgotten his exposure. Then he suddenly comes down with the fever and his whole world, I think, turns topsy-turvy. So association of pre-existing patient characteristics at survival, I think all these things are very important, the so-called comorbids, which have such a great influence on the ultimate survival of the patient, whether it's diabetes, whether it's hypertension, whether it's anything else, renal failure, anything else for that matter. I think we need to take these people with a huge pinch of salt and with a great deal of responsibility and make sure that they are catered to as properly as possible. So history of travel to a location, we're talking a lot about travel, and I think we've forgotten what travel is like. And I think we'll very quickly forget what an airplane looks like for that matter. And I think this is very important. So we had contact confirmed, we looked at contact transmission, we looked at contact tracing, and then of course we looked at the hospitals, and today we have multiple hospitals, multiple facilities, multiple level of facilities that deal with patients right from home quarantine to quarantine in a quarantine center, then to go to a first level hospital, and then finally to a tertiary level hospital to try and treat yourself. So there are various modalities of care. The whole point in question is that who decides who goes where? And I think that's a very key call in this matter. And how quickly you decide and how rightly you decide that this patient needs to go somewhere. I think Dr. Richard did speak about the stages and the pulse oximetry readings and the breath rates. You know, all those things are important. Instinctively, I think we have now developed this tendency of trying to find out what the real problem is and where they need to be sent. So I think chest X-ray, the other abnormalities, of course, aminotransferase levels, C-reactive D-dimer, ferritin, lactate. We've been talking about this for a hell of a long time. I think the treatment course, symptoms of onset and trying to flatten the curve. Everybody knows what the curve is today, but nobody really knows where it's going to take us. So I think that's the effective thing that we have today. Now, this was my first patient with COVID, and this was about 4 months ago, I think. This guy landed in Chennai airport 15 minutes before they closed the air travel. The air travel, they closed at 12 midnight. He landed up at 11:45. And he called from the airport saying, "Sir, I have fever. I've been having cough for the past 15, 20 days. It was coming from Paris." And I told him, at this point of time, there's nothing for you to do. Go and lock yourself up at home. don't get any contact with anybody. 3-4 days later, he developed more and more fever and breathlessness. And this is the X-ray that he had. I'm sorry, this is a bad X-ray that was sent by WhatsApp. And I think it's a kind reminder for people to use WhatsApp the way it needs to be used. But we can clearly see that there are ground glass opacities that are here. This guy needed nothing but azithromycin and paracetamol with oxygen. He was in hospital for about 5-6 days. Then they had an exit COVID at 9 to 10 days, and he was discharged and back home. So this is one of the better stories I started off with. And then, of course, we know that there are a huge population which have this mild infection. And I think this is really what we need to understand. Now, what is mild infection? When does mild infection go into severe infection? What is the so-called tipping point that tips these people off into others? What modalities do we use to find this tipping point? How do we teach patients to find this tipping point? And I think that's very important. You can tell them, look at your fever, again, very relative. Look at your breathlessness, quite relative, reasonably relative. Look at other things like body pain, which are extremely unrelative for that matter. The pulse oximetry is probably the most relative thing that I can think about. If a person feels that his pulse oximetry is coming down consistently over a period of time, I think that is the time that he needs to go around. I think this mild, moderate, severe has been seen. And this, I believe, is the culprit of all that happens. And I think this is the devil. This is the devil in the works for the SARS and the MERS and the COVID-2 that we see. And one really doesn't know why God created such organs. So I think the markets in Wuhan, I think those are important. I think if there's one thing that we need to understand, this is the slide that we need to understand. Incubation, a prodromal phase, and then you draw the red line. The minute you draw the red line, you're getting into more difficult territory, which means that you're getting into a stage of pneumonia. There are quite a few people who recover from the pneumonia, but once you get into the immunological state and you have the so-called cytokine storm, I think we are looking at a totally different kettle of fish altogether. So I think we need to understand and sort of verticalize these things into 3 or 4 verticals and try and see what is the thing that tips from one vertical to the other, because more than 80 to 90% of patients will do with verticals 1 and verticals 2, and there are very few people who go into vertical 3 and vertical 4, and I think we need to understand. We're talking about the RO, the sort of comparison with measles, one really needs to understand. But I think one thing that we need to understand with the SARS-CoV-2, that it's got an RO which is very high, much, much higher than the other viruses that we've seen. So its ability to infect more and more people, I think, becomes more and more difficult. And I think we've been seeing this with the antibodies. We can keep talking about these antibodies for a very, very long time. Whether they are good, they are bad or ugly, one really does not know. But I think we need to have developed some modality of some sort of rapid testing, because today our testing takes a lot of time. In government hospitals, it takes as much as 5 days to 1 week for the results to come. And God knows if the patient is going to be alive after 5 or 10 days. So chest X-ray, and I think I thought I'd just delve with the chest X-rays for a wee bit. Please understand, please remember that all these X-rays that I'm going to follow are taken from radiology. They are not my X-rays. I thought I need to display straight X-rays, which are sort of documented as such, bilateral ground glass opacities with a posterior dominance. And I think this is very, very nicely depicted here. The ground glassing, which is sort of uniform, and of posterior predominance. We have the crazy paving pattern that we see, thickened interlocular lines in combination with the ground glass pattern. Then, of course, we have a CT vascular differentiation. And I think this is a very ominous sign. The minute you start seeing signs of vascular dilatation, you know that you're going in for trouble, because we understand today that all the ARDS and the things that are followed are a result of the vasculopathy and the microemboli that are released from the pulmonary circulation into the systemic circulation, and then producing ARDS and all the other symptoms that we have, I think are important. So vasculature, I think, is important, which is the reason why today in treatment gives so much of importance to things like low molecular weight heparin and things like that. Keep monitoring that very frequently. A lot of people even go back on things like ribavirin and other anticoagulants that they need to take over a period of time. They are cumbersome drugs. We understand that they are drugs that need to be supervised, but I think that they need to be used, but they need to be used with caution. So traction bronchiectasis is something that we've seen in the area of ground glassing. This is a very classical feature, ground glassing plus bronchiectasis plus traction bronchiectasis. There's nothing else in the diagnosis today other than COVID. And I think subpleural bands and architectural distortion in India, in a country like India, where there is so much of TB and fibrosis, I think this can become a problem. But we need to understand that there is a pattern like this itself. Now, one word about the so-called assessment scores that we're talking about. People have started looking at assessment scores like they look at their blood sugars, and I think that's a misnomer. I don't honestly think people should look at assessment scores because all assessment scores are visual scores. What is blue to me may be bluish gray to you, something like that. So we need to understand and tell patients that visual scores are visual scores, and so be it. They are not the gospel. They are not like the blood sugar, where 300 is distinctly more than 100, and we know that it is so. So I think we need to get them to understand that. Now we have a scoring system that we have for the lobes as such, and the total severity score. I think all of us are very compatible with this. But I think the only caution that I will give with this is that patients need to be told that these are visual scores. These are not calculated scores that are calculated out of a laboratory. So ground glass, bilateral, posterior, multilobar, peripheral. The consolidation, of course, is something that is seen again. Now, I think this again is important. A lot of people develop the pneumonia before they become positive. That's what is important. One word on the RT-PCR, I think what we have seen so far over the past 3 months, that the RT-PCR is not the gospel. And the RT-PCR does not mean that you do not have disease. And only 60 to 70% or maybe probably 75% of patients test positive for RT-PCR. There are a lot of people with classic COVID pneumonias who go through the whole episode of COVID pneumonia being RT positive negative. And I think I will show you some CTs towards the end in just a couple of slides. But I think it sort of tells us that the RT-PCR is not the end all as far as the diagnosis is concerned. So it starts from a GGO pattern, progressive, then it goes into a crazy paving pattern, consolidation, and gradual fibrosis. And I think these are the images that we're really going to look at. So the absent features, I think, of a COVID are important. No consolidation, very little of that. Lack of ground glass, no cavitation, no lymphadenopathy, no pleural effusion, no tree in bud opacities, and recognizing the complex nature of these patients, the history that they have, and also probably looking at the comorbids, I think are important. Drugs, I think we've seen a lot of this, antiviral agents, anti-inflammatory agents, and whatnot. Lymphopenia is something that's been a very steady parameter that we have looked at, and I think it's still an extremely parameter to look at. If there's one slide that we should take off, I think this is what it is. You have the viral phase and you have the post-inflammatory response phase, and I think this is really what it is. You cross stage 2 and then you're asking for trouble, and that's what it is. And I think it's a wonderful way of trying to describe to patients that as long as you're in the viral phase or in the viral phase, as we call that, you have this chance of coming back. Whereas if you go into the inflammatory phase, the point really is that what tips this thing off when we don't know. The one thing that we've seen is that late reporting probably tips off the host inflammatory phase more than early reporting. That's the only thing that we can see today. There is no biochemical value. There are a lot of these inflammatory markers that we use, the CRP, the D-dimer, and the ferritin, and things like that. But we understand that they are not absolutes to be used in a situation like this. So the comorbids, I think, are important. Drugs, of course, are remdesivir. We have lopinavir, ritonavir, which we know are useless today. We've been using chloroquine, and hydroxychloroquine has always been a matter of talk. And everybody talks about hydroxychloroquine. Even this tea-selling guy down the street knows what hydroxychloroquine is today, knows what virus is, knows what vaccine is, knows what isolation is, knows what a mask is, knows what social distancing is. And I think if the virus is taught us something, it is that. The vasculopathy is something that I think we need to really concentrate upon, because I think the vasculopathy is responsible for a lot of these deaths that we're looking at. And that's the reason why I think the low molecular weight heparin and the sort of anticoagulation becomes extremely important in these people, not to say the steroids that we need to use in these people as such. So progressive of supportive care would be early intubation if it's necessary, sedation, paralysis, and probably go to ECMO the last. Then, of course, we know that there are probably two phenotypes even on the ventilator. Different ventilatory management, the L and the other type. So I think it's important that we learn these things and we understand that we need to intubate patients when they need to be intubated. But the one thing that we have learned very clearly is that the minute you get onto the ventilator, your mortality goes up rocketing, skyrocketing. And I think it is our duty to try and prevent these people from going into this very, very difficult circle. Prone positioning, all of us have understood the need for prone positioning and also the fact that you have excellent response from this. A lot of nutrients, there was a talk about nutrients and COVID, and L-arginine is something that's been very, very highly talked about, especially because of the vascular effect that he has. The COVID experience, I think all of us knows. But the one thing that I would really like to understand is that this guy had a very mild exhibition of COVID on his CT, then went into the ventilator, and he was on the ventilator for about 4 days. There does not appear to be a very clear correlation between extent of CT involvement and extent of disease, at least in about 40 to 60% of patients that we see. I'm not saying that everybody fits into this category, but I think we need to be extremely cautious. Look at this guy. This was a guy that I saw about four months ago, I think. He came and sat in front of me. He had climbed 2 flights of stairs up because he didn't want to use the lift. So he came up and sat in front of me, very comfortable, no cough, nothing. And he put out his CT, which looked like this. And 4 months ago, I got a shock of my life. I almost got a heart attack when I saw this CT because I never seen anything like this before, 4 to 5 months ago. Now, this guy has been in a government hospital for 3 weeks. They've done 4 COVIDs and all the COVIDs were negative. No COVID was positive, whether it was the government hospital to blame or whether it was the disease to blame or whether he was to blame or poor technique was to blame, I don't know. The fact remains that 4 COVIDs were negative, so they didn't know. He was very comfortable. He was saturating on room air and doing extremely well. Little breathlessness, little cough here and there, nothing more than that. So the people in the government hospital didn't know what to do, so they said, you please go home. This guy gathers all his things and comes to me, climbs 2 stairs and comes sits in front of me, and I get a heart attack. And I said, with folded hands, I told him, sir, please go home, lock yourself up, don't go anywhere, just continue to take the paracetamol, please buy a pulse oximeter on the way and keep checking this and stay at home and call me every single day in the evening. I certainly will not be disturbed. For 10 days, I didn't hear from him at all. 12 days later, I hear from him. He calls me on the monitor and says, sir, I'm in a place about 300 kilometers from Chennai. I don't know how he got there in those days of real lockdown. But he's 300 kilometers. He has taken nothing. And he now says that he can climb 4 flights of stairs. He's going about his farming work without any problem. And I'm just waiting for this guy to come back. Once the sort of lockdown and the traffic is eased out, he will come back and I will want to take a CT for him. The point I put this up is that there are a lot of people with extensive CT presentation, but who do extremely well for some reason or the other one really does not know. There's another picture of the same person. But I think I'll just stop with 5-6 myths that I think we need to do. Myth number 1, holding your breath for 10 seconds without discomfort means you are free from any respiratory disorder. Myth 1, absolutely wrong, cannot have anything that's right. UV lamp skill can be used to disinfect everything. I think these can be said only about heads of states. Heads of states have fantastic medical things that suddenly medical knowledge comes from heaven and sits on them and they come up with fantastic statements. And I don't really think I need to elaborate on this. Myth, spraying alcohol or chlorine all over your body kills the virus. And I think that's a myth again that we need to understand. Routine vaccines against pneumococcus and influenza are good, but they don't have any action against the COVID. And I think this is something that we need to understand. We need to understand and tell them that COVID is different from the others, and a necessity to tell them again, I think, are important. I'll just close with these words that were occurred in that were spelled out in April of 2018. There's one area though where the world isn't making much progress, and that's pandemic preparedness. This was said in 2018, and I think these are sort of astronomical words that were uttered by Bill Gates, and I think that's something that we need to prepare about. And I have to remind yourself again, ladies and gentlemen, the next world war is not going to be fought by Rafales and Sukhois. It's going to be fought by one vial of virus that's being thrown on a country. And unless we do something to try and cross this, stop this war between the environment and mankind, the way we treat the environment and nature will not look upon us with courtesy or love. Thank you very much for the patient hearing.
Thank you, Dr. Thomas. That was wonderful. You have in such a short time given us a wonderful overview of the clinical profile which we as need in our day-to-day management of this dreaded disease. So with that, I'm going to move to the next part of the discussion, which is the panel discussion.
Thomas, sir, can you stop sharing the screen, sir?
Yeah, 1 minute, sorry.
Can you please stop sharing the screen from your end?
I will stop sharing. Where does yeah. Have I done that? Okay. That was more by default than intent.
Can you see my screen?
Yes, sir, we can see.
And handsome Dr. Animesh Arya?
Yeah, exactly.
Correct. So it's my pleasure to introduce my dear friend, Dr. Animesh Arya. He's the director at the Diseases, Allergy and Sleep Disorders in New Delhi. He's the head of the Department of Chest Medicine at the Action Medical Center and the Action Cancer Hospital. He's very experienced with 35 years of in allergy, sleep, and pulmonology. An astute bedside clinician, he is a member of the National Task Force on Home NIV and various advisory boards of asthma, COPD. He has multiple publications to his credit, and it's a pleasure to have shared the Dr. Animesh. Welcome, Animesh, to the panel. We look forward to your thoughts and comments. Also, Dr. Meghanand is an ENT surgeon, so he brings a different experience to our discussions today. He has, again, a vast experience from the Postgraduate Institute of Chandigarh, one of the most prestigious institutes in India. He has special skills in skull-based endoscopic surgery, and he's been the editor of the book on FES, which is skull-based surgery and endoscopic surgery. He has done laser-assisted MLS, stapedectomies, and has his own technique for mastoidectomy, where the virus enters. So, panel, I'm going to stop my screen share. Okay, good. So with this esteemed panel, we now open the have any questions from the audience, or should I start?
Sir, we have a lot of questions from audience, but we can have an initial round of discussion and then I will start putting the questions to you.
No, fair enough.
Okay, so
Go ahead, Dr. Rohit. why don't you start with what the audience wants?
So one of the frequent queries which audience has, there are multiple repetition of the same question is when exactly would you start Favipiravir? Is it in the mild cases or would you still wait for some time and would you start in the moderate cases?
Yeah, that's a
So,
great question. I think the way to answer that question is not to say, well, we should start at mild or moderate or asymptomatic, but once you have onset of symptoms, it's important to try to get the drug into your system as soon as possible. So we know that even without any sort of intervention, on average, the patients will be going negative for the virus in about 10 days, right? So any meaningful outcome that we can achieve by intervening with Favipiravir or other similar oral antiviral drugs would be beneficial at an earlier stage. So if you confirm a case today and the patient had onset of symptoms, let's say 3 days ago, I would administer the drug right away. There are a number of exceptions, and specifically, as Dr. Thomas was discussing, you do have varying degrees of outcome associated with age and other risk factors. So let's say, for example, I had a 20-year-old patient, no significant history, very healthy, who presented with a slight cough. Okay, would I be very interested in aggressively treating this patient with Favipiravir? Not likely, because we know that most likely that patient in his 20s, early 20s, is going to get better without any intervention, especially with a drug like Favipiravir. Although we're very careful about who we administer the drug to, how the drug is administered, how we educate the patient, and if it's a male patient, of course, we'll make sure that they promise that they will not engage in unprotected sexual activity for a period of 7 days after the drug has stopped, right? But let's say we have another patient, a 67-year-old female patient who has come in with a history of type 2 diabetes. She's obese and has a history of cardiovascular disease as well. So now in this patient, even if their, let's say onset symptom is again 3 days, I would treat that patient much more aggressively. Why? Because one, her symptoms may still be mild, but we want to keep it that way. And we know that a patient in their 60s, late 60s, is going to have a higher case fatality ratio, and also could have a greater risk of dying from the disease or developing a more severe form of disease. So we want to try to get the drug into those patients earlier.
I have a follow-up question to that. Thank you very much, Dr. Kaczynski. And this was in a previous panel. To family members of a symptomatic patient. This question came up because we have families where one person is symptomatic and may be admitted to hospital. And up until now, there was nothing else that we could do. But like they've used oseltamivir in the past, thoughts beyond this, please?
Yeah, thank you very much, Dr. Mehta. I lost you for a second there, but I think I understand your question. So I think your question is, what do we do in the event that we have a family member who is tested positive and is living together with at-risk populations? And this is a very important question. It's actually a great follow-up question, and one that is being specifically addressed right now in Canada. And I think you may have seen on the news today about the FDA approving the same approach that's being taken by Canada. So I think if you go back to my slides about the post-exposure prophylaxis and also pre-exposure prophylaxis, this is something that I think addresses your question specifically. So let's say we have that 30-year-old patient. Again, this patient who's in their 30s, who doesn't have any significant medical history, is most likely not going to succumb to the disease or die from the disease, or most likely he's not even going to develop any severe forms of disease. And again, there are the exceptions, but from a statistical standpoint, that patient in their early 30s is not going to develop a severe form of disease that requires some sort of hospitalization or admission to the ICU, or maybe even death. But Your question is great because it addresses the fact that many families would like to have addressed, right? There's a lot of families who are living together with their parents or maybe even their grandparents. And what do we do in those cases? Of course, that 30-year-old may not die, but that 30-year-old may, in fact, infect their grandparents who are in their 70s or 80s or 90s that have a higher risk of developing severe disease. And one of the things that they're looking at specifically in the Canadian study is this pre-exposure prophylaxis. So in essence, it's almost like using it in a vaccine method. So you're taking the drug before you're being exposed, just in case you do have accidental exposure, you already have an effective blood concentration that will prevent you from developing the disease. Maybe you've been exposed to the virus, but you're not going to develop COVID-19. And this is actually showing some very promising results in long-term care facilities in Canada. And therefore, the company Ebela that's actually running these pre-exposure prophylaxis trials has applied for an extended phase 2, I believe, in the US. And that's what they're going to be doing in the US as well. But definitely shows promise. So it's very important because before we actually develop a viable vaccine solution, this would be something that could fill that void. Not only that, but even once we have a vaccine that is properly developed, a lot of patients who are in the elderly category, so if we're talking about 60s, 70s, 80-year-old patients, you can give the vaccines, but that doesn't necessarily translate into the production of neutralizing antibodies in these patients. So for those patients, this could definitely be a viable option to consider as well.
Thank you. Thank you. I think that's very helpful for a lot of our patients. Dr. Rohit, any question?
Yes, sir, one of the follow-up questions. So we have answered about the pre-exposure prophylaxis. So this has also come up very frequently in the question box. But apart from that, there are also doctors who are asking about how do you compare Favipiravir with Lopinavir-Ritonavir, considering earlier it was a part of the WHO Solidarity trial. It was also considered to be a potential anti-COVID medication. So how do you compare it with Favipiravir?
So this.
Yeah. Oh no, sorry. Go ahead.
Richard, your mic is muted.
Okay. So is it okay for me to answer this?
Yes.
That's fine.
Okay. With regard to Lopinavir-Ritonavir, which goes by the product name Coletra, there's a study that was conducted in China that we addressed today, and it was a direct comparison. It was Favipiravir versus Coletra. The only difference in this study, which made it slightly unique, is that it was, in essence, a combination therapy because it was Favipiravir plus interferon and standard of care versus Lopinavir-Ritonavir combination plus interferon and standard of care. But even in that study, there was a significant difference between the two groups. So, is Coletra a miracle cure? It definitely doesn't look like it, at least at this stage. I will mention that the Chinese study that was conducted was limited in terms of the actual number of patients that were recruited. So again, there's a number of limitations associated with these studies, but I mean, when we talk about the WHO and the Solidarity trials, I'm not the biggest fan of the WHO, and I apologize if there's a number of WHO fans here, but I think the way that the WHO actually handled the situation in the very beginning was not the best. Let's say, for a better lack of a better phrase, let's just say it wasn't the best approach. Even in their initial adoption of various drugs to screen in that Solidarity trial, Favipiravir was marginalized. They were aware of it, but they didn't include it. It was the ugly girl at the prom, basically. Nobody was looking at it. And the reason why is because everybody was so fixated on the fact that the drug has this potential, or at least showed the potential, to induce fetal toxicity or teratogenicity in these animal studies, right? But there's a long-standing legacy in terms of the use of this drug on human patients. And like I said, what is the actual number of patients, human patients, that have actually been documented to have favipiravir-induced teratogenicity or fetal toxicity? The answer is zero. There's no documented cases that have actually been attributed specifically to the use of favipiravir. And one of the things that we want to do, and especially with this audience of younger doctors who are not too familiar with the drug or not too experienced with treatment to begin with, is we really want them to keep this legacy alive of safety, right? And that's why there are rules that with any new drug of this capacity, you always want to be careful about how you first educate your physicians on how to use the drug. And then next, if the physicians are properly educated, they can continue that chain of education and trickle that down to the patients that they are seeing and that they are going to administer the drug to. So it's really a matter of how we properly educate our staff who are actually on the ground and who are treating patients. And if we do our job properly of educating the physicians on the ground, then I think we could really mitigate the risks of having teratogenicity or human fetal toxicity issues down the road.
So I think Dr. Mehta is on call. Dr. Meghnad, you wanted to come in?
Yeah. Many times we are seeing the patients with anosmia, but RT-PCR is negative, no other symptoms, only anosmia. We pretty well know that we have never seen this kind of anosmia patients before the COVID started. So most probably this is because of the COVID. So in an isolated symptom of anosmia, can we start the Favipiravir or not? Richard?
Yeah, that's a great question. Again, anosmia is actually one of the signature, let's say, symptoms associated with COVID-19, but it is also important to note that anosmia is not specific to COVID-19 alone. So there are other causes for anosmia. So just because the patient is presenting with anosmia is not an implication that the patient is COVID-19 positive. So if a patient comes in with complaints of anosmia, you would go through your standard protocol of clinical diagnostics. You would engage the patient, see what their vital signs are. Does the patient have a fever? Does the patient have any other signature symptoms like myalgia, diarrhea, lethargy, anything like that? And then, of course, you would do the RT-PCR. And as Dr. Thomas importantly noted, it's not, RT-PCR is not infallible. It's not 100%. And a lot of times, I think we're very dependent on RT-PCR, and we tend to enter this erroneous comfort zone when we conduct the RT-PCR and we find a negative result, and we say, oh, thank goodness, the patient is not COVID-19 positive, which is not the case though, because any number of issues can go wrong that would result in that false negative, right? Maybe the patient, the sampling was done incorrectly, right? Or also, I mean, the test has its inherent limitations. But just going back to your question, if a patient does present with anosmia, and you go through the entire process, you do the RT-PCR, and the patient is found to be positive for RT-PCR, COVID-19 positive, then I would engage the patient right away. But again, it would depend, at least in my case, I would consider what the age range of the patient was. So again, if it's a female patient of childbearing age, let's say 25 years old, she just got married, maybe she wants to have kids right away, then would I engage that patient aggressively with Favipiravir? Most likely not. No. Because again, the statistics would show that this patient will most likely go on to not develop any severe forms of disease. So it's always a trade-off. Now, on the opposite end of the spectrum, let's say we have a patient who is complaining of anosmia, but it's an 88-year-old gentleman with a history of type 2 diabetes, and the RT-PCR came back positive. Would I give the patient the drug right away? Absolutely. Before his condition deteriorated, I would absolutely aggressively treat that patient, because one course of Favipiravir would cost in India, I think it costs about maybe less than $100, right? And that's a lot cheaper and a lot less labor than having that patient go on to develop COVID-19 pneumonia and have him administered to the ICU, or God forbid, have that patient die. So, if it was my mother or grandmother who was in that position, who is not of childbearing age and does not have, that risk of teratogenicity, fetal toxicity, I would aggressively pursue treatment.
Thank you. And I think I was doing a mental calculation. It probably comes to about $50 for a course. But I'd like to bring Sharia into this. Animesh, what is your experience with Favipiravir, particularly in the Delhi environment? And how do your respond to the use of these drugs? And any other comments you may have coming out of Delhi? What's your experience?
Yeah, thank you, Sanjeev, and thank you, Richard, for such a nice presentation. There were a few comments and few questions, of course, as Sanjeev also asked. So one comment would be that all these studies which have been shown have used Favipiravir or Lotanavir and Navir combination with interferon. But what we are advocating or using them is only sole use of Favipiravir. So it's always been crossing minds of clinician. Are we doing the right thing in only using Favipiravir alone? Number one. And as Dr. Meghnad has used in about 100 patients, we have used in less number of patients. I may have used in about 20 to 25 patients so far. And the complication, as he also mentioned, that we do get a common symptom as diarrhea. And if you see per se the diarrhea, it is little confusing whether the symptom is due to the disease per se or to Favipiravir. And then it is a little difficult for a patient to understand to keep taking medications even up to 14 days, and when the symptoms are abating in an OPD practice, and he feels a little at loss to get to the base of it, that how should you and why should you take it. But now we understand from your talk and the literature that it is primarily also preventing the progression to a serious COVID pneumonia. And that is what we should be advocating upfront to all our patients, to prevent them going into a serious paradigm of COVID pneumonia, sepsis, septic shock, or any thrombotic complications like acute kidney failure, or maybe some neurological complications. So I think that is a very good cue what we have got from here. And just two comments, Dr. Meghnad, more. And so experience with us in Delhi, as Sanjeev asked me, is a little limited. And because we still are holding fort with hydroxychloroquine, let me be very frank, Sanjeev. So because it still forms a continued mention in the Ministry of Health and Family Welfare guidelines, and so also in All India Institute guidelines, to treat patients with hydroxychloroquine with an ECG upfront and monitor it closely. And of course, none of the other things do find a mention, though DCGI has made an approval for Favipiravir. So we, as a collective opinion in Delhi, we are a little not so, you can say, into use of Favipiravir so far. But that question still looms large. Alone, would it be as effective as shown in the trials in the Japanese study or in the Chinese study?
Thank you. I must say, we go straight up front. A patient gets admitted to the hospital. If he's not in the ICU, most of us would give Favipiravir.
Sanjeev, you're not audible.
Yeah, I think.
I'm sorry. Did I mute it? I'm sorry. Is that a little better? I'll come closer to my. Yeah. Pretty extensively, and our major side effect has been joint pains, hyperuricemia. But thank you. But Dr. Thomas, you wanted to have.
No, I think in my book there are only two things. One is the age, two is the comorbidities, and three are the clinical symptoms. I won't be too interested in an RT-PCR, though I will send it side by side. But if my clinical instinct tells me that the age and the symptoms are consistent with COVID, and today every fever is COVID unless proved otherwise, I would rather start the Favipiravir early rather than wait for them to develop hypoxia and look at the pulse oximeter and things like that. I would do it long before. I would get the cart moving rather than just staying put in and keeping quiet. And after that, I think we can monitor them. And so far, I've had no regrets whatsoever. 100%. I have not had any regrets at all. Most of my patients are sitting at home looking at their pulse oximeters. And I thought the sort of initial loading dose would be a real problem with patients. But I think if you say COVID, patients are willing to stand on a finger if you want. There's no question about it. So they take it. And I think my experience has been very satisfactory. But I have not really used it in the very severe type. I should again confess that to you. I have not used it in the severe COVID type. Once I get into the ICU, I don't really get too much involved in that. But I think the mild to moderate, which I think is very, very important, it's because we mismanage the mild to moderate that they get there in the first place. So my thing would be hit hard and hit early.
Yeah, most of the patients are taking the medication for 14 days. So how I came to know is, see, this some of the one brand is selling at 34 tablet strip, right? If you calculate, they're falling short. So they're coming back to me, sir, the chemist is not giving me 4 tablets loose. So what I started keeping a strip and I'm cutting 4 tablets and giving them. So most of the patients are taking the full course. And the only thing I have observed is the diarrhea. And another thing is, surprisingly, the uric acid levels are not increased very badly in our population. I have done the estimation of the uric acid before and after 14 days and at the end of 7 days also. Only in one patient, the liver enzymes have increased, but the uric acid levels are more or less same, around 5 only, not much. None of our patients have complained of arthritis. This is what we have observed. I might have treated around 100 patients with Favipiravir.
Thank you. Thank you for the.
I have one question to Dr. Richard. By chance, if a patient had a recurrence of the disease and in the first incident you have used the Favipiravir, can you give it again?
Thank you very much for that question, Dr. Meghana. Yeah, the quick answer to that would be yes, absolutely. You would definitely want, because this is still a novel therapeutic, it's still an experimental therapeutic, you would always want to monitor certain parameters in terms of adverse events. There's some reports of QT prolongation. Obviously there's that one case report that just came out regarding the acute gouty arthritis. But again, I think the experience that we have so far is very consistent with what you just mentioned, and that although we do notice that the uric acid levels do increase, they are more than often subclinical. So even if we do see the numbers start to come up, it's not like the patients are complaining of arthritic pain. So yeah, we're definitely on the same page there. And I think Dr. Mehta and Dr. Thomas kind of touched on this as well. But we were also under the assumption when we first started this, 1,800 milligrams BID on day 1, followed by 800 milligrams BID on day 2 and beyond. Sounds like a lot of pills to take. But in the scope of things, it's not like you have to take all 9 pills in one gulp, right? You can break that down into 2 pills per gulp if you wanted to break that down into 3 gulps. And when we're talking about elderly patients, they're already used to multi-pharma. So these patients are already taking 8 pills, 9 pills, 10 pills. Now, when you actually look at what we were doing back in the Ebola days in West Africa, for the treatments then, we were doing 6,000 milligrams on day 1. 6,000 milligrams is 30 pills on the first day. So if you think 18 pills is a lot, I mean, it's almost double the amount of what we were using in the past. And when we were using greater quantities of the drug, that's when there started to be a little more prominence in terms of the adverse effects. But with that said, the adverse effects are pretty on par with what we're seeing right now. It's not like we're seeing something completely new that we haven't seen before in the treatment of COVID-19 versus the treatment of Ebola during the JIKI trial or these previous trials for Ebola virus disease. So that's something important to know. But I would echo the plea by Dr. Thomas and saying that, if we do have a patient and we know this patient has a number of risk factors for this person to go on and develop more severe forms of disease, although this is an experimental therapeutic, I would totally echo the notion that early treatment is the best option for these patients. I'll give you an example. If it was my mother, I mean, this is experimental treatment, but if it was my mother and my mother came to me with COVID-like symptoms and it wasn't that serious, it was just mild. If we did an RT-PCR, she turned up positive, I would guarantee you that if I had Favipiravir, I would give it to her. And that's how I would treat my own family, let's say.
Can I ask a provocative question? And I know there's no science to it, but if there's any clinical thoughts from anybody in the panel and Dr. Richard.
You're not audible.
But any thoughts?
Sorry, you want to repeat
your question?
We couldn't hear you.
So question is Favipiravir, Severe, assuming the patient can take both. Any thoughts on the head-to-head comparison? It's probably no. Could you hear me?
No.
Favipiravir versus, sir, the second part.
Versus remdesivir.
Okay.
This is for patients who get hospitalized and are, just borderline. And the question is, do you want to hit them with remdesivir or with Favipiravir?
I've got an answer that I can share, but I'll let Dr. Thomas or Dr. Arya or whoever go first if they'd like. If not, I'll jump in.
No. Richard, you go ahead.
Okay, so with regard to remdesivir, I think that the remdesivir drug, at least in its current state, it's an injectable formulation.
Yes.
So that would limit the use of the drug to you have to be hospitalized. It's not realistic for us to actually be using remdesivir on an outpatient basis. So just with that alone, I think that would really kind of limit our options, or it would actually exclude the vast majority of patients. And Dr. Thomas did a great job of showing us that the vast majority, 80% of the patients that actually test positive for COVID-19 are patients that have no business anywhere near a hospital. And I think it's the fact that in the very beginning of the pandemic, we were trying to cater to all of these patients who were just testing positive, but who were displaying only mild or maybe even asymptomatic patients. And we were cradling them in our limited hospital and healthcare facilities. And this was really choking the medical infrastructure of pretty much every country in the world that I could at least think of. So the best treatment, I think, moving forward would be to actually have a viable option to treat patients in the outpatient setting, which would, of course, imply that these would be mild patients, or maybe, patients who are just coming out, breaking out of their asymptomatic shells and starting to develop COVID-19 like symptoms. Those patients would be a great start. And again, at least I would consider what patients that they are. I wouldn't just say, okay, well, you're mild, so let's give you some Favipiravir. I would consider your background, your history, your risk factors, and then give you the drug. But let's say, for example, you have a patient that bridges that barrier. They were mild patients to begin with, but they transcended into a more severe state that required them to be admitted to the ICU. So, that transition would be a great time to actually use remdesivir. Now, are there any rules that would preclude us from combining the use of remdesivir with Favipiravir? And the answer to that would be no. There are no precluding factors, I would say, that would limit us to say, no, oh, you're using remdesivir, so let's not, let's stop giving you favipiravir. There's no need to do that. And you saw on the data that I showed you for the Japanese observational trials that although the severe patients, the drug isn't as effective on severe patients, but it does show to some degree an efficacy, a very promising degree of effectiveness on that category of patient that fit that severe clinical category. So that would be definitely something that I would consider. Combination therapy is something that now that we know that the standalone therapy for favipiravir is eliciting promising results, although non-conclusive, because a lot of these studies have been limited phase 2 studies. Very, very few phase 3 studies have been conducted today. So they're limited, but they're very promising, right? And so now that we see that trajectory of the drug, we're already kind of breaking out of this standalone therapy bubble. We're already taking into consideration other combination therapies. And I'll give you a few examples. I think you guys are familiar with the drug ivermectin, which is the anti-parasitic drug. That's one of the drugs that have been shown to exert very promising results when used in a combination setting with favipiravir. There's also other drugs like nafamostat or camostat that are interesting as well. But nafamostat is an injectable solution, so it's very difficult to try to combine a oral pill with a injectable formulation. So again, with regard to nafamostat, we're kind of looking at camostat, because camostat is the oral version of that drug, and it would make combination therapy that much easier. But one last thing I'll add, and I apologize for going on too long, is that there are a number of drugs that we do not want to use together with favipiravir, and the reason why is very it's very varied. For example, pyrazinamide, we don't want to use that together with favipiravir because it basically it increases the uric acid levels more than it would when you're using favipiravir alone. So if you're using favipiravir together with pyrazinamide, then your uric acid levels would increase significantly. Repaglinid is another one that we don't want to use. Theophylline is also another one that we don't want to use, but that's included in the manufacturer's brochure with the drug. So that's something definitely that we want to have your doctors on the ground be familiar with before they start dispensing the drug. And I apologize for going on long.
What about the use in children?
Yeah, that's also a great question. I think when we're dealing with pediatric cases, there are, of course, the unique cases that do result in death or admission to the ICU. But again, it's a very rare case, I think, at least from the data that has been accumulated to date. So would I actively seek usage of the drug in pediatric cases? The answer, unfortunately, would be no. And another reason why is because we have very limited experience with the drug on pediatric cases to begin with. For the most part, any of the studies that you encounter that have been conducted in the past have focused primarily on adult patients, above the age of 18. So, but with that said, again, if you're faced with a situation in which you are seeing a rapid decline in the patient's health, then it might be something to consider. Would I do it right now? The answer would be no, and the reason why is because we simply don't have that clinical justification. We don't have that evidence to justify that use. So I would be very careful and measured in the approach for pediatric cases.
Thank you. That was very helpful, Richard. Any last questions?
Yes, sir. So, I mean, there are more than 200 to 50 plus questions, but most of them have been answered. One thing which is coming up very frequently is it has been shown that favipiravir is excreted in semen. There's some amount of favipiravir found. So, what are the cautions? So, if you can also highlight what are the cautions to be taken up by the patients while consuming favipiravir overall?
Effective contraception.
Protection.
protection.
Effective contraception.
Protection is very important up to 7 days after discontinuing the medication.
Yep, exactly. Yeah. I would just add there's an interesting. Oh, no, go ahead, doctor. Sorry.
And would you frequently monitor the serum uric acid level and liver enzymes after Favipiravir, or how do you do it, sir, in terms of monitoring?
I do it every week.
I do it weekly too. That's the way we do it. Patient is symptomatic, in which case we do it earlier.
Great, sir. I think we have answered all the queries regarding Favipiravir and its role in mild to moderate set of patients. So, Mehta, sir, any closing remarks you would like to?
No.
I have a question to you, Dr. Rohit.
Yes.
What is the pricing of this in India?
Good question. Good question.
Great question, sir. We have our division head, Yogesh. He would be a better person to give that perspective. Yogesh, are you there? Can you there?
Yes, I'm there. Yeah, thanks, doctor, for the question. So we are pricing this product as 99 rupees a tablet in India.
Good.
And that's the price. And as we've seen
One
in the
thing
beginning,
I liked very much is as I told, it is available 122 tablets, a full course. That's a
Yes.
very good point.
yes.
In fact, in between, we faced a lot of problem when it is out of stock in the market.
Yeah.
Patients come back to, sir, ये नहीं मिल रहा है, क्या करेंगे, sir? It's a very bad situation.
Yeah.
Now, I'm very happy to see this 122 tablets, a full course.
Yes.
Some other brand is making 34 tablets. You will never catch
Yeah.
122. You have to cut the strip. And the chemists, usually, they don't like to cut it.
Yes. So it's like, we've seen that in the beginning when these products were launched in the market.
I think
lot of
you
patients
had a
were not,
first-hand experience. Of
Yeah, they were not getting the second strip, third strip, and then there was a lot of struggle for the patients.
And
So
the last strip, you can't get it.
Yeah.
Yeah.
So
Yogesh, is that 99 rupees and 99 paise?
no, sir.
No.
Right.
Then you've gone out of the Bata circle.
I think they will reduce the price in due course.
And one more thing, sir. These
Anyway, it's interesting.
are being imported from Japan, sir. So
Yeah, I understand. No,
It-
that was just by the way, nothing else.
I think very much. I'd like to thank Dr. Richard for that wonderful, very insightful talk. Dr. Thomas for
You're not audible.
he brings such wisdom and clinical experience to our talks. Dr. Arya, Dr. Meghna, thank you very much for the wonderful thoughts. Rohit and the team from Dr. Reddy's for making this happen, for providing this platform for this discussion. I am enlightened. Sure, so are all your audience members. I hope you've had a enjoyable and
Sure, sir. Thank you so much, sir, and thank you every one of you for sparing your time for this scientific symposium. And have a nice day, and again, happy Independence Day to all.
thank you. Same to you.
All right, thank you, everyone.
Thank
Thank
you
you,
all.
Dr. Richard. Stay
especially
safe. God
Dr.
bless you.
Richard.
Thank you, guys. Look forward to doing this again.
Okay.
Bye. Thank you. Bye.
Thank you.
Bye,
Thank
Sanjeev.
you.
Thank you, sir.
Yeah,
Bye,
thank
bye.
you. Thank
Thank
you.
Jay, we can take it offline.
Thank you.
Thanks a lot, sir. Thank you.
Thank you. Thank you very much.
Thanks.
Jay, are we offline?
No, sir. No, sir.
Just take offline.
Yeah, done.
Thank you.
Thank you, sir.
Thanks, Jay. Thanks for the support. Thanks,
Thank you.
Dr. Mittal.